1, 2,
And
Patients here.
female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's charter book.
300 please.
I'll keep your card again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the echo people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
Okay.
Oh.
Alright guys, so here is something that's going to be very important for nurses here in the United States. If you are a nurse in the United States in a state that has banned abortion, then this particular med is going to be very important for you to know. Yes, this med is often indicated as like a chemotherapy agent. If I'm not mistaken, I think it's a folic acid inhibitor or folate acid inhibitor, something like that. It has something to do with the inhibition of folate acid metabolism or whatnot. But this med came under major scrutiny here in the state of Texas a few years ago when the state decided that abortions would no longer be legal in the state of Texas. Now, this is not a political thing or anything of the matter. This is just the facts. So methotrexate is often used as a medication to complete or induce abortions, elective abortions or elective termination of pregnancy, however you want to look at it. This is the drug that they typically will use. One dose of one high dose of methotrexate, and usually it will dissolve the pregnancy. So it's very important. So if you are a nurse here in the States or you are a nurse in a country, because I have listeners all over the world, if you are in a nation or a state in the United States that bans abortion, then knowing this drug will be of utmost importance to you, because there's a lot of controversy around this drug and a few other drugs that were also used to terminate pregnancies, but mainly this one. So if you guys, like I said, it's very important for you guys to know this drug and how to handle it and whatnot. So yeah. In the state of Texas, this drug is very controversial, and a lot of other states that ban abortion as well. And I'm sure in other nations that also ban abortions as well. So anyways, that's my 2 cents. Enjoy the episode.
Imagine a drug that is like so incredibly toxic that actually administering it requires a literal rescue mission.
Right. It's intense.
Yeah, you hook the patient up to an IV, infuse this massive dose of chemicals designed to bring their cellular machinery to just a grinding halt.
Yeah.
And then you're literally watching the clock.
Because if you miss the window.
Exactly. If you don't administer the chemical antidote, the parachute, at the exact required hour, that first drug will kill the patient.
It absolutely will.
But then, and this is the wild part, imagine that same exact drug is sitting in the medicine cabinets of millions of people right now.
Just casually, yeah.
Right. People who swallow a few pills safely every single week to treat their arthritis.
It really sounds like an impossible contradiction, doesn't it?
It totally does.
But, in the landscape of clinical pharmacology, that kind of duality is actually what makes a medication so profound.
Yeah, you're talking about a chemical that is just entirely dependent on the context.
Exactly. The context of its administration is everything.
And if you are listening to this right now, chances are you're in the thick of nursing school, or maybe you're a new grad hitting the floor.
Staring down an absolute avalanche of medication profiles, probably.
Oh, the worst. You're trying to figure out how to safely administer drugs that have the power to heal a patient miraculously. Or, if misunderstood by even a fraction of a milligram, cause severe harm.
Yeah, and today we are doing a deep dive into the ultimate pharmacological skeleton key, methotrexate.
Methotrexate. Just hearing the name probably gives some of you nursing students a little tachycardia.
Well, the clinical profile and the safety manual for methotrexate is massive, and I mean, for good reason.
It's a heavy hitter.
It is. It's one of the most complex and frequently tested drugs in the clinical arsenal. But pharmacology is, it's too often taught as a series of endless, disconnected lists to memorize.
Right, like indications, contraindications,
Well,
adverse effects.
Dosages. It all just becomes a blur.
Which is why our mission today is to apply the Pareto principle, the 80-20 rule.
I love that approach for exam prep.
Yeah, we are going to extract the 20% of the core foundational concepts about methotrexate that will yield 80% of the overall understanding you need.
Not just to completely crush your licensure exams, but to actually practice safely at the bedside.
Exactly. So to do that, we really have to establish what methotrexate actually is at its chemical core.
Right. So structurally, it is a folic acid analog. That's its foundational identity.
Okay, a folic acid analog.
Yeah, but clinically, it wears a lot of hats. It's classified as an antimetabolite, an immunosuppressant, an anti-rheumatic, and an anti-psoriatic.
So depending on how you turn that skeleton key-like, depending on the dosage and the protocol, it can aggressively shut down tumor growth, or it can gently dial back an overactive immune system.
That's it. But because it interacts so fundamentally with cell division and, human immunity, the safety guardrails required to use it are colossal.
And as a nurse, you are the final checkpoint before that drug enters the patient's body.
You're the one managing those guardrails.
So true. So before we even touch on the side effects or the boxed warnings, we need to talk about the mechanism of action.
Yes, because when you understand the cellular mechanism, the side effects aren't just random facts you're forcing into your short-term memory.
Right, they become entirely predictable, logical consequences.
You can almost see them coming before they happen.
Okay, so let's look at the first phase of methotrexate, the cancer killer. How does it actually work when a patient has a malignant tumor and we're trying to eradicate it?
Okay, so to understand the malignant mechanism, we have to look at a specific enzyme inside our cells called dihydrofolate reductase.
Dihydrofolate reductase, got it.
Yeah. Think of this enzyme as a vital manufacturing plant. Normally, a cell takes in folic acid, which we get from our diet, right? Leafy greens, beans, fortified grains.
Right.
But dietary folic acid is inactive. It doesn't actually do anything on its own.
Oh, interesting.
Yeah, it has to be converted by dihydrofolate reductase into its active form, which is called tetrahydrofolate.
Okay, so tetrahydrofolate is the actual usable product. What does the cell use it for?
It's essentially the biological currency for replication. The cell needs reduced folates to synthesize DNA, to produce RNA, and to replicate its proteins.
So if a cell cannot make DNA, it can't divide.
Exactly. It's stuck. Now, methotrexate is a master impersonator.
How so?
Well, structurally, it looks incredibly similar to normal folic acid. So the cell eagerly takes up the methotrexate, and the enzyme, dihydrofolate reductase, binds to it, fully expecting to process normal folate.
But it's a trap.
It is a massive trap. Methotrexate competitively inhibits that enzyme. It binds to it with an incredibly high affinity and just refuses to let go.
It jams the gears of the manufacturing plant.
Exactly.
So the cell is starved of active folate, and the entire assembly line for DNA synthesis just grinds to a halt.
That is the core mechanism of an antimetabolite, and this makes methotrexate what we call a cycle-specific drug.
Right, go back to cell biology.
Yeah, when you study cell division, you have the G1 phase of growth, the S phase of DNA synthesis, the G2 phase, and mitosis.
Okay.
Methotrexate specifically targets cells that are actively in the S phase.
Oh, wow. So it only works on a cell when that cell is actively trying to build new DNA.
Precisely.
And the therapeutic effect here is, brilliant for oncology. Because malignant cancer cells are notorious for dividing recklessly, right?
Yeah, they ignore all the body's stop signals.
They're constantly throwing themselves into the S phase, making them highly vulnerable to a drug that poisons that exact step of the process.
That is the intended therapeutic effect, yes.
Yeah.
But here's the catch.
There's always a catch.
The drug does not have a homing beacon. It cannot differentiate between a malignant osteosarcoma cell and a perfectly healthy human cell that just happens to be dividing.
Which bridges us perfectly to the bedside reality for the nurse.
Exactly.
Because if the drug attacks any rapidly dividing cell, we really don't need a textbook to tell us the side effects. We just have to look at human anatomy and ask, well, what cells are constantly dividing in a healthy person?
And the list is surprisingly short, but vital.
Let's list them out. The hair follicles are always growing, pushing out new cells constantly.
Right.
The gastrointestinal mucosa, like the lining from your mouth all the way down to your colon, is constantly shedding and replacing itself to deal with, the friction and acid of digestion.
Yeah. And bone marrow.
Oh, yeah. The bone marrow is basically a factory operating in overdrive, pumping out millions of red blood cells, white blood cells, and platelets every single second.
And of course, fetal cells if a patient happens to be pregnant.
Right, because organogenesis is nothing but rapid, explosive cell division.
Exactly. By identifying those 4 anatomical areas, you have instantly memorized the most common and severe side effects of high-dose methotrexate.
It's like a cheat code for the NCLEX.
It really is. You've got alopecia, which is hair loss. Severe gastrointestinal toxicity like stomatitis.
Those are the painful mouth ulcers, right?
Yeah, and massive diarrhea as the gut lining actually sloughs off. Then you've got bone marrow suppression leading to anemia, neutropenia, and thrombocytopenia. And severe fetal harm.
You just follow the biology, and the nursing implications reveal themselves.
It really makes complete sense when you look at it that way.
It totally does. But, reading through the research, there's another piece to this cancer mechanism that feels almost predatory on the cellular level.
Oh, you're talking about polyglutamation?
Yes. Polyglutamation. Can we break that down? Because the notes suggest this is why the drug is so devastatingly effective.
It's a fascinating biochemical trap. So when a cell takes in normal folate, it attaches a tail of glutamic acid molecules to it.
Okay, a tail.
Yeah, this tail makes the folate bulky. It ensures it stays inside the cell so it can be used for metabolism rather than just floating back out through the cell membrane.
So it's a retention mechanism. It's kind of like a hoarder bringing a piece of furniture into their house and immediately boarding up the door so nobody can take it away.
That's actually a very accurate way to look at it.
Wow.
The problem for the cancer cell is that when it eagerly drags methotrexate inside, thinking it's food, it applies that exact same process.
Oh, wow.
The cell actively adds a glutamic acid side chain to the methotrexate molecule.
The cell boards up its own doors.
Yes. The drug is now trapped inside the intracellular space and cannot easily cross back out.
So the cell's own greedy biology becomes the instrument of its destruction.
It does. And what's even more devastating for the cell is that this polyglutamated form of methotrexate is actually an even more powerful inhibitor of the target enzymes than the original drug molecule.
Wait, really?
Yeah. The cell builds its own poison, traps it inside, and amplifies its lethality.
That is just incredible. And, from a nursing perspective, that explains why the drug's effects can last so long. And why prolonged exposure, even at seemingly lower serum concentrations, can result in serious, lingering cellular toxicity. The drug isn't just floating in the blood, it's literally trapped inside the tissues.
Which becomes a major, major factor when we discuss how to rescue a patient from these high doses later on.
Okay, but let's pivot for a moment. We've explored the aggressive cancer-killing mechanism. What about the other face of the drug?
The autoimmune side.
Right. Methotrexate is the gold standard therapy for severe rheumatoid arthritis, polyarticular juvenile idiopathic arthritis, and severe psoriasis.
It is.
And this is where I really want to push back on the pharmacology because it feels completely counterintuitive.
Oh, so?
Well, how does the drug know to act as an immune calmer instead of a cancer killer? If a patient with rheumatoid arthritis takes this drug, why doesn't their bone marrow just completely shut down?
That's a great question. It comes down to a shift in the primary biochemical target based on the dosage. When we use methotrexate in low doses for non-malignant autoimmune diseases, the concentration isn't high enough to completely shut down DNA synthesis via dihydrofolate reductase.
So it's not jamming the main factory.
Right. Instead, the drug starts interacting prominently with other folate-dependent enzymes. And the most critical one for the autoimmune mechanism is called AICAR transformylase.
AICAR transformylase. That sounds like something out of a biochemistry nightmare.
It's a mouthful, I know.
The Li5 that. Explain it like I'm 5. What happens when methotrexate blocks that specific enzyme?
Okay, so when AICAR transformylase is inhibited, it triggers a metabolic traffic jam inside the cell.
A traffic jam.
Yeah, and this traffic jam ultimately results in a massive accumulation of a substance called adenosine, which then spills out into the extracellular space.
Wait, adenosine? Like the cardiac drug?
The exact same molecule, yeah.
In nursing school, we usually drill adenosine in cardiac contexts. It's the drug you push rapidly for supraventricular tachycardia to essentially reboot the heart's electrical system.
It is. But here we're looking at its role in the immune system.
Okay, so what did it do there?
In the immune system, extracellular adenosine acts as a powerful systemic anti-inflammatory signal.
Oh, fascinating.
Yeah, increased adenosine binds to specific receptors on the surface of immune cells and essentially broadcasts a stand-down order.
A stand-down order.
Right. It inhibits the proliferation of T and B lymphocytes, you know, the specialized soldiers of the immune system.
Right.
It also suppresses the secretion of pro-inflammatory cytokines, which are the chemical alarms of the immune system.
So we're talking about suppressing things like interleukin-1, interferon gamma, tumor necrosis factor.
Exactly, all of those.
Oh, that makes so much sense. Because in a disease like rheumatoid arthritis, the immune system is fundamentally confused.
It's aggressively attacking the synovial tissue of the patient's own joints,
creating chronic, incredibly painful inflammation. So this accumulation of adenosine acts like a heavy, wet blanket thrown over that entire inflammatory fire.
That is the perfect visualization. It selectively dials down the replication and aggressiveness of those overactive T and B lymphocytes.
Wow.
And on top of that, it also decreases macrophage and neutrophil chemotaxis.
Okay, let's define chemotaxis for the listener just to be safe. That's essentially the chemical trail of breadcrumbs that tells white blood cells where to go, right?
Correct. So methotrexate not only calms the immune cells down, it also blinds them to the site of inflammation.
Stopping them from swarming the joints in RA or, the skin in psoriasis.
Exactly. And it does all of this without completely destroying the patient's ability to make baseline blood cells, which is what would happen at cancer level doses.
Bridging this back to nursing practice. If you deeply understand these two distinct mechanisms, the high-dose DNA blockade for cancer and the low-dose adenosine wet blanket for autoimmune disease, you are perfectly positioned to anticipate your nursing interventions.
The mechanism completely dictates the management.
Right. You know that a cancer patient is going to face intense, rapid cellular die-off side effects, while an RA patient will experience a more gradual immunosuppressive effect requiring long-term monitoring.
Because the therapeutic goal depends so heavily on the condition being treated, the dosages, the administration routes, and the safety protocols differ drastically.
Which brings us out of the theoretical biochemistry and into the how.
Let's get into it. How do we actually give this drug safely?
Let's talk indications, dosages, routes, and the all-important high-dose rescue protocols.
Sounds good.
So, for indications, the malignant side includes breast cancer, non-Hodgkin lymphoma, acute lymphoblastic leukemia, often referred to as all osteosarcoma, and meningeal leukemia.
And on the non-malignant side, we've mentioned rheumatoid arthritis, juvenile idiopathic arthritis, and severe recalcitrant psoriasis that just isn't responding to standard topical therapies or light therapy.
Okay, so the routes of administration for methotrexate really highlight its versatility.
They do. It can be given PO, meaning by mouth.
Right.
It can be given IM, intramuscularly, intravenously, subcutaneously, and even intrathecally, which means injected directly into the cerebrospinal fluid within the spinal canal.
Wow. But the dosages, this is the critical exam material right here.
Oh, absolutely.
This is where the difference between a therapeutic intervention and a fatal medication error is razor thin. So let's start with the low-dose protocol for those non-malignant indications.
Okay, so for rheumatoid arthritis and psoriasis, we use the low-dose protocol. The typical adult dose might be 20 milligrams orally for RA or up to 30 milligrams orally for psoriasis.
Okay, 20 to 30 milligrams.
Yes. And the most vital piece of information you can take away from this entire discussion, if you remember nothing else, is the frequency.
Yes.
It is dosed weekly.
I really want to stop and highlight that because it literally cannot be overstated. Weekly, not daily.
Weekly. This is one of the most classic, frequently tested, and unfortunately most fatal medication errors in modern medicine.
It's tragic.
It is. Picture a scenario. A patient is prescribed methotrexate 20 milligrams weekly for their arthritis. but the prescription is written poorly, or the pharmacy label is confusing, or the patient simply misunderstands the verbal instructions.
Which happens all the time.
Right. They go home and they take 20 milligrams every single day.
Oh, man. Let's walk through that simulated timeline because that is terrifying. If they take it on Monday, they're fine.
Tuesday, they take it again, still mostly fine.
But by Wednesday, they have essentially initiated a rogue chemotherapy regimen in their own kitchen.
Exactly. On day 3 or 4, they might notice their mouth feeling sensitive. Stomatitis begins.
The mucosal lining of their mouth is failing to replace itself.
Right. By day 5, they are experiencing severe diarrhea because the intestinal lining is sloughing off.
And then by day 7,
they present to the emergency department feeling profoundly weak, feverish, and bleeding from their gums.
and when the ER nurse draws their CBC, the complete blood count, what do they see?
Catastrophic bone marrow suppression. Pancytopenia.
Pancytopenia, meaning essentially 0 white blood cells to fight infection, critically low red blood cells causing profound anemia, and 0 platelets to stop bleeding.
It is a devastating, often unrecoverable error because by the time they actually present to the ER, the tissues are fully saturated with that polyglutamated methotrexate.
Trapped in the cells.
Trapped.
So as a nurse, when you're doing patient education for RA or psoriasis, you are the last line of defense against that exact scenario.
You really are. You must ensure the patient can teach back to you that they take this drug on one specific day of the week, and that's it.
Take it on Methotrexate Monday or whatever day works for them. Just make it an unbreakable weekly ritual.
Patient education is the absolute primary nursing intervention for low-dose therapy.
Okay, so now let's swing the pendulum to the high-dose malignant side.
Oh, this is a whole different ballgame.
The numbers we deal with in oncology are staggering compared to that 20 milligram weekly dose.
They are. The source material is very clear about the massive variation. In the treatment of neoplastic disease, the dose can range from 80 to 900 milligrams per square meter of body surface area given IV without rescue therapy.
But then it escalates.
Oh, it escalates. It can go from 900 up to an astronomical 30,000 milligrams per square meter IV when used with rescue therapy.
30,000 milligrams. That is a massive volume of a highly toxic chemical being infused directly into the vascular system.
It is. It's also important to note, just from a pharmacological perspective, that oral doses greater than 30 milligrams per square meter are poor choices due to extremely erratic and bad absorption in the gut.
So these massive doses are always administered intravenously.
Always.
Which brings us to the caveat you mentioned. With rescue therapy.
Yes.
Picture this scenario. It's 2 a.m. on an oncology unit. You're holding a bag of IV methotrexate containing tens of thousands of milligrams. You know this dose is lethal. You're purposefully giving an amount that will eradicate the osteosarcoma, but it will absolutely kill the patient if you do not intervene. What is the nursing management of this high-wire act?
This is where clinical vigilance is absolutely paramount. The intervention is the leucovorin rescue.
Leucovorin.
Yes, leucovorin is a reduced active form of folic acid. If you recall our discussion on the mechanism, methotrexate competitively blocks the enzyme that converts inactive folate into active folate.
Oh, so leucovorin bypasses that blocked enzyme entirely.
Exactly. It provides the active, usable folate directly to the starving cells.
It's the parachute. You push the patient out of the plane with a lethal dose of methotrexate, and leucovorin is the parachute you deploy to stop them from hitting the ground.
That's a great way to put it.
But wait, if you're giving them the exact nutrient they need to start dividing again, won't that also rescue the cancer cells?
That's the million-dollar question. The entire protocol relies on precise pharmacokinetics and timing.
Okay, walk me through the timing.
The methotrexate is infused, and it floods the body. Because the cancer cells are actively dividing at a chaotic rate, they take up the methotrexate incredibly aggressively. They gorge on it.
Right.
Then, after a very strictly timed interval, usually 24 to 36 hours after the methotrexate infusion began, you administer the leucovorin.
So by that time, the methotrexate has already done its lethal, irreversible damage to the cancer cells.
Exactly. The cancer cells are functionally destroyed, but the normal healthy cells in the bone marrow and the GI tract, which divide slightly slower and take up the drug slightly less aggressively, are just standing on the precipice of death.
Wow.
The leucovorin enters those healthy cells, restarts their DNA synthesis, and rescues them from the toxicity. It saves the patient's life.
The precision required for that is just immense. The clinical manual states that leucovorin rescue is mandatory in all patients receiving methotrexate injection at doses greater than 500 milligrams per square meter.
And it should be highly considered for doses between 100 and 400.
And the timing of the leucovorin administration is an absolute non-negotiable nursing priority.
Oh, without a doubt. If a leucovorin dose is scheduled for 14.0, it cannot be given at 15.0.
Because delays can result in irreversible fatal bone marrow failure.
Yes. Throughout this whole process, you are drawing methotrexate blood serum concentrations at least daily, sometimes every few hours, just to adjust the subsequent leucovorin dosing.
So leucovorin is the parachute. But while this massive amount of drug is circulating, the patient's kidneys are taking the brunt of the processing load.
They're doing all the heavy lifting.
The outline mentions 2 mandatory nursing interventions here. Aggressive hydration and alkalinization. We need to grease the brakes so the kidneys don't lock up. Why is this specific chemistry so dangerous to the renal system?
Okay, so methotrexate is eliminated primarily intact by the kidneys. When you give these massive high doses, the concentration of the drug in the renal tubules becomes incredibly dense. And methotrexate and its metabolites are weak acids. In a normal or slightly acidic urine environment, they are highly prone to precipitating.
Let's visualize that. Precipitating means they stop being dissolved in the liquid and turn into solid crystals.
Yes.
It's like thousands of microscopic, jagged kidney stones forming instantly inside the nephrons.
That is exactly what happens. The crystals physically obstruct the microscopic tubules of the kidneys, causing an immediate back pressure that destroys the nephrons.
Oh my gosh.
This causes irreversible acute renal failure. The kidneys simply lock up, which means the methotrexate can no longer be excreted.
Which means serum levels skyrocket, leading to catastrophic systemic toxicity.
It's the ultimate vicious cycle.
So to prevent this, the nursing management requires massive IV hydration to keep the flow rate high, constantly diluting the drug as it passes through the kidneys.
Hydration is key, but hydration isn't enough on its own. You must alkalinize the urine.
Right. So you administer intravenous sodium bicarbonate before the first dose of methotrexate and continue continuously throughout the treatment.
Exactly.
And what is the specific physiological goal there? Like, what pH are we aiming for?
The core nursing intervention is to test the urine pH, often with every single void or at least every few hours, and maintain a urinary pH of 7.0 or higher.
A pH of 7 or higher.
Right. That shifts the chemistry of the urine, keeping the methotrexate in a highly soluble state, which completely prevents the crystallization.
So if you are working that 2 a.m. shift and the patient voids, and you test the urine and it drops to a pH of 6.5.
You do not open the roller clamp on that methotrexate.
Wow. You hold the drug, you contact the provider, and you give more bicarbonate until that urine is alkaline again.
You are literally manipulating the chemistry of the patient's urine to keep a life-saving drug from destroying their organs.
That is the epitome of critical care nursing.
It really is.
But we must also plan for the worst-case scenario. What happens if the parachute fails?
The nightmare scenario.
Yeah. What if the patient had an underlying undetected renal impairment? The drug didn't clear, and now they have deeply toxic plasma concentrations circulating in their blood.
Well, if the kidneys fail, the methotrexate just keeps recirculating, continuously blocking the enzymes. Leucovorin alone won't be enough to combat that volume of drug.
So what do we do?
In these critical life or death cases, the manual introduces an antidote called glucarpidase.
Glucarpidase, how does that function?
It's an exogenous enzyme, meaning it's an enzyme produced outside the body and injected into the bloodstream.
Okay.
When injected, it rapidly cleaves or chops up the circulating methotrexate molecule into inactive metabolites.
I love the visualization of this. It's essentially sending a rogue chemical hitman directly into the bloodstream to assassinate the methotrexate molecules before they can even reach the kidneys.
That is a very visceral but very accurate way to describe it.
It's cool, though.
It is. Those newly chopped up inactive metabolites are then easily processed by the liver, completely bypassing the failed kidneys.
That's amazing.
Yeah. Glucarpidase rapidly reduces toxic plasma concentrations, specifically indicated when levels are greater than 1 micromole per liter in the setting of delayed clearance due to renal impairment.
Okay, to summarize the massive undertaking of the high-dose protocol, it requires the massive dose of IV methotrexate, mandatory aggressive IV hydration, mandatory urine alkalinization to a pH of 7 or higher, strictly timed leucovorin rescue, and glucarpidase kept on standby for toxic levels in the presence of renal failure.
That sequence of care truly highlights why the manual states that administration requires an experienced clinician.
It's a choreographed dance with a very dangerous chemical.
Absolutely.
Which leads us to the do not cross lines. We know how powerful this drug is and the extreme lengths we go to manage its toxicity in a healthy patient who should never get this drug under normal circumstances. Let's dive into the contraindications.
Contraindications are critical because they represent situations where the physiological risk of the drug so vastly outweighs any potential therapeutic benefit that its use is deemed medically unacceptable.
Makes sense.
The first and most absolute contraindication for methotrexate is pregnancy, specifically in women being treated for non-malignant diseases like rheumatoid arthritis or psoriasis.
And again, we aren't just memorizing a list. This loops directly back to the mechanism of action.
Always back to the mechanism.
Because methotrexate ruthlessly targets rapidly dividing cells in the S phase, a developing embryo is the ultimate susceptible target.
Yes.
The cellular replication happening in embryogenesis, like building a nervous system, building a heart from scratch, is essentially the exact biological process methotrexate is designed to stop.
Methotrexate is a profound teratogen. It causes intrauterine fetal death, spontaneous abortions, and severe congenital anomalies.
That's so heavy.
It is. The clinical profile notes that exposure during the first trimester is deeply associated with facial dysmorphism, central nervous system abnormalities, skull anomalies, and cardiac defects.
It just disrupts the fundamental blueprint of the developing fetus. There is a really stark, heartbreaking data point in the research. A prospective multi-center study looked at pregnant women who were inadvertently exposed to 30 milligrams per week or less. We were talking about the low-dose protocol used for arthritis.
Right.
The rate of spontaneous abortion or miscarriage in that group was 42.5%.
Almost half.
Almost half of all pregnancies ending in miscarriage just from the low-dose exposure.
And of the pregnancies that resulted in live births, the rate of major birth defects was significantly higher than in unexposed patients.
Wow.
Because methotrexate is widely distributed in the body's water and persists in the tissues for a prolonged period, due to that intracellular polyglutamation trapping we discussed earlier, there is even a potential risk to the fetus from preconception exposure.
Okay, I want to push back on a specific phrasing in the manual, though, because it highlights an incredible ethical and clinical tension.
Okay, what is it?
The manual says it is contraindicated for pregnancy in non-malignant diseases. Does that mean a pregnant woman with cancer might still get this drug? Because that sounds absolutely terrifying given the teratogenic mechanisms you just described.
It is a profound clinical dilemma, and one that requires a huge multidisciplinary ethics and oncology team to navigate.
I can imagine.
The distinction in the manual exists because in a non-malignant disease like rheumatoid arthritis, while it is incredibly painful and debilitating, it is not immediately life-threatening to the mother.
Right.
Therefore, risking the life of the fetus is completely unacceptable. However, if a pregnant woman is diagnosed with an aggressive, highly lethal malignancy like acute lymphoblastic leukemia, the priority medically shifts to saving the mother's life.
So in those rare, highly complex cases, if neoplastic disease treatment is absolutely necessary to save the mother, methotrexate can be used.
It can.
But there's a massive formulation caveat if it has to be used in that scenario, right?
Yes. If it must be used, the clinician must select a preservative-free formulation of IV methotrexate.
Okay, why preservative-free?
Many standard liquid formulations of medications contain a preservative called benzyl alcohol to prevent bacterial growth in the vial.
Oh, benzyl alcohol.
Yeah. Benzyl alcohol can cross the placenta and is highly toxic to fetuses and neonates. So, while the risk to the fetus from the methotrexate itself remains extreme, we at least remove the secondary guaranteed toxicity of the preservative.
That perfectly segues into another major contraindication, neonates and intrathecal administration.
Yeah.
You just mentioned benzyl alcohol.
Right.
The manual is incredibly clear. Do not use formulations containing benzyl alcohol for neonates, low birth weight infants, or for intrathecal injections, meaning injections directly into the spinal fluid.
Never.
Why is that specific preservative so dangerous? Let's break down the mechanism.
Okay, so benzyl alcohol is a relatively harmless preservative for a healthy adult, but it cannot be metabolized effectively by the immature liver of a neonate.
It builds up.
It builds up rapidly in their system and causes a devastating condition called gasping syndrome.
Oh, that sounds awful. What does gasping syndrome look like clinically?
It's characterized by severe central nervous system toxicity, profound metabolic acidosis, gasping respirations, hence the name severe hypotension, cardiovascular collapse, and ultimately death.
That's horrifying.
It is. Furthermore, when giving medications intrathecally to anyone, adult or child, you are intentionally bypassing the blood-brain barrier.
Right.
Introducing a preservative like benzyl alcohol directly into the delicate ecosystem of the cerebrospinal fluid can cause severe, irreversible neurotoxicity.
So always check the vial. If you are drawing up a dose that is going into a baby or going into a spine, you must physically verify it is preservative-free.
That is a classic high-stakes nursing exam question right there. Which vial do you select? The answer is always the preservative-free option for intrathecal or neonatal use.
Awesome tip. Okay, moving to the contraindications. What are the other major red flags?
Alcoholism, alcoholic liver disease, and other chronic hepatic diseases.
Because methotrexate is metabolized by the liver, it undergoes enterohepatic circulation, and it's inherently hepatotoxic.
Exactly.
Let's stop in ELI5 enterohepatic circulation, because that term gets thrown around in pharmacology a lot. Enteral refers to the gut. Hepatic refers to the liver. This is essentially a toxic recycling loop, right?
Yeah.
The liver processes the drug, dumps it into the intestines through the bile to be excreted in stool, but the intestines just absorb a large portion of the drug right back into the bloodstream.
That is precisely how it works. It creates a continuous loop of exposure for the liver.
Wow.
The liver has to process the same molecules of methotrexate multiple times before they finally escape the body.
Oh, so if a patient already has a compromised liver from chronic alcohol abuse or hepatitis, the liver simply cannot handle that repetitive toxic burden.
Not at all. Giving them methotrexate is a recipe for accelerating fibrosis and pushing them straight into full-blown cirrhosis or acute liver failure.
So practically speaking, if you are an outpatient clinic nurse doing an intake assessment on a new rheumatoid arthritis patient, and during the social history they mention they drink a 6-pack of beer every night to help with the joint pain,
That is a massive, flashing red flag.
you need to hold the prescription and communicate that to the provider immediately before starting methotrexate.
Absolutely. The baseline health of the liver must be respected.
What else?
Another absolute contraindication is pre-existing blood dyscrasias. We are talking about conditions like bone marrow hypoplasia, severe leukemia, thrombocytopenia, or significant anemia.
Which again traces right back to the S-phase mechanism. If the bone marrow factory is already broken, underperforming, or damaged by another disease, you cannot introduce a chemical that suppresses cellular replication further.
You will entirely wipe out their remaining ability to produce blood cells.
Right.
And finally, methotrexate should be used with extreme caution and is often strictly contraindicated in the presence of an active infection.
Because it's such a potent immunosuppressant, it strips away the body's defenses.
Exactly. A standard, easily manageable bacterial infection can become rapidly overwhelming and fatal.
It can also cause the reactivation of latent viral infections that the immune system was previously keeping in check.
The manual specifically notes that if a patient on methotrexate presents with new pulmonary symptoms, the possibility of an opportunistic infection, such as pneumocystis jirovecii pneumonia, must be immediately considered.
So to recap the do not cross lines for our listeners, no pregnancy for autoimmune use, no benzyl alcohol for babies or spinal taps, no heavy drinkers or liver disease patients, no pre-existing bone marrow failure, and no active infections.
That paints a very clear picture of the robust baseline health a patient requires before starting this drug safely.
But the clinical reality is that patients don't exist in a vacuum. What happens if the patient is a perfect candidate? Their liver enzymes are great, they aren't pregnant, their blood counts are robust.
That's always something else, right?
Right. What other drugs or underlying physiological conditions can sneak in and turn a completely safe therapeutic dose into a lethal one? Let's talk about the deadly combos.
Drug interactions and special fluid dynamics.
This is where vigilant nursing assessment is paramount, because patients often have massive blind spots when it comes to over-the-counter medications. They don't consider them to be real drugs.
And that blind spot can be fatal. The most dangerous, unexpectedly lethal interaction with methotrexate is with NSAIDs, nonsteroidal anti-inflammatory drugs.
We're talking about common household names, ibuprofen, naproxen, celecoxib,
Yes.
which is incredibly insidious. Think about the patient population we are treating. What does a patient with rheumatoid arthritis naturally reach for when they have joint pain?
NSAIDs. They are in every single medicine cabinet in the world.
How does an over-the-counter painkiller turn methotrexate deadly?
Well, the concomitant administration of methotrexate, especially at higher doses, along with NSAIDs, can lead to unexpectedly severe, sometimes fatal bone marrow suppression, aplastic anemia, and severe gastrointestinal toxicity.
And what's the mechanism there?
The mechanism lies in renal blood flow. NSAIDs work by inhibiting the synthesis of prostaglandins.
Let's break that down. Prostaglandins cause pain and inflammation, which is why blocking them makes your headache go away.
Right.
But prostaglandins also have a protective role in the kidneys. Right. They keep the blood vessels leading into the kidneys dilated.
Exactly. Prostaglandins ensure the kidneys get adequate high-pressure blood flow to filter waste.
So by inhibiting prostaglandins,
NSAIDs clamp down on those blood vessels. They drastically decrease the kidney's glomerular filtration rate.
because methotrexate is cleared by the kidneys, this reduction in blood flow means the kidneys lose their ability to excrete the methotrexate efficiently.
The exit door is suddenly half closed.
Wow.
Yes. So the methotrexate builds up in the bloodstream to highly toxic levels.
That's terrifying.
It gets worse. Furthermore, some NSAIDs can physically displace methotrexate from plasma proteins.
Displace it.
Yeah. Methotrexate travels through the blood, bound to proteins. If an NSAID knocks it off the protein, it decreases the amount of free, highly active drug in the bloodstream.
So it's a two-pronged attack. More active drug circulating and less drug being cleared.
Which leads to profound systemic toxicity.
The nursing implication here requires aggressive patient education. If a patient comes into the clinic for their Whitley methotrexate dose and casually mentions they've been popping ibuprofen all week for a tension headache,
You do not administer the methotrexate.
you hold the dose, assess for toxicity, and notify the provider.
Patients must be heavily educated to avoid NSAIDs without explicit case-by-case physician approval while on this therapy.
Without question. Similarly, any concurrent use of other nephrotoxic drugs that inherently damage or stress the kidneys, like certain strong antibiotics, aminoglycosides, or IV contrast dyes, will increase the risk of toxicity by prolonging those elevated methotrexate serum concentrations.
If the kidneys are stressed, the methotrexate just won't clear.
Okay, there's one more special dynamic in the manual that I found absolutely fascinating. It's not a drug interaction, but a physiological state of the patient's own body that traps the drug.
The third space trap.
Yes. Can we explore how ascites or pleural effusions affect methotrexate elimination?
This is a really critical piece of advanced nursing assessment. Third spacing refers to fluid accumulating in areas of the body where it isn't easily exchanged with the rest of the extracellular fluid or the bloodstream.
Like where?
Well, ascites is the massive accumulation of fluid in the peritoneal cavity of the abdomen, often from liver disease or advanced cancer. Pleural effusion is fluid trapped in the space around the lungs.
So we have these stagnant pools of fluid sitting inside the body.
When you administer the site methotrexate, the drug distributes widely throughout all of the body's water. It leaches seamlessly into that third space fluid. The problem arises during elimination. The third space fluid acts like a giant, stagnant, toxic sponge. As the kidneys do their job and clear the methotrexate from the main bloodstream, the serum concentration in the blood drops appropriately.
But the concentration inside the ascites fluid remains incredibly high.
Exactly. It creates a vast concentration gradient. So over the next several days, the methotrexate slowly leaches back out of the ascites sponge and into the bloodstream,
Constantly repopulating the blood with the drug long after the initial infusion has ended.
It drastically prolongs the exposure time of the body's cells to the drug, which, as we discussed with polyglutamation, dramatically increases cellular toxicity.
Let's expand on an analogy here.
Yeah.
It's like having a slow leak in a toxic waste barrel buried in your backyard.
Pretty much.
You think the drug has cleared the body, you check the initial blood levels 24 hours later and think you are safe, but it's hiding in that pleural effusion, continuously poisoning the patient days later when you aren't looking.
That is the exact physiological danger. The nursing management for this is absolute.
What does the manual say?
It states clearly, remove significant third space fluid prior to treatment.
So if a patient has significant ascites, they need a paracentesis, a needle aspiration, to drain the abdominal fluid before you hang the methotrexate bag.
Right. And if they have a pleural effusion, they need a thoracentesis. If you don't drain the reservoir, you cannot safely manage or predict the drug's clearance.
That is such a vital, tangible nursing intervention. When you walk into the patient's room, you check for peripheral edema, you assess their abdomen for ascites, and you listen to their lung sounds before starting the infusion.
If you identify third spacing, you stop and advocate for fluid removal.
It's all connected. The assessment drives the safety protocol.
It really does.
Which brings us to the core of the nursing exam material, the most feared section of any complex drug profile, the boxed warnings.
The black box warnings.
These are the most serious safety alerts the FDA can require.
And for methotrexate, there are several boxed warnings, and they cover almost every major body system.
Instead of just reading down the list anatomically, let's group these logically based on the mechanisms we've discussed. Let's start with the rapid cellular replication crisis.
Okay.
These are the boxed warnings directly tied to methotrexate attacking cells in the S phase.
The most immediate consequence of the S phase attack is on the hematologic system. The boxed warning states that methotrexate causes severe, life-threatening bone marrow suppression.
And clinically, this manifests as neutropenia, a dangerous drop in white blood cells, placing the patient at risk for rapid fatal infections.
It also causes thrombocytopenia, a drop in platelets, risking spontaneous internal bleeding,
Right.
and in severe cases, aplastic anemia, which is a total catastrophic failure of the marrow to produce any blood cells at all.
From a nursing management perspective, what is the protocol to catch this before it becomes fatal?
You must obtain baseline complete blood counts, or CBCs, before starting therapy,
And
and then monitor them at least monthly during treatment, and much more frequently during initial dosing or any dose escalations.
And your physical nursing assessment needs to be hypervigilant for subtle signs of infection, right?
Yes. A low-grade fever, a sore throat, general malaise.
And signs of bleeding petechiae on the skin, unexplained bruising, bleeding gums when brushing teeth, or melena, which are dark, tarry stools indicating upper GI bleeding.
Absolutely.
And what is the immediate action if you see a significant drop? Say the patient's white blood cell count plummets from a healthy 6.0 down to 1.5.
The action is immediate cessation.
Just stop the drug.
If there is a significant drop in blood counts, the drug must be withheld. The manual specifically notes that subcutaneous formulations must be stopped immediately.
And then you provide intense supportive care.
Right, which might include broad-spectrum IV antibiotics for neutropenic fever or platelet transfusions to prevent hemorrhage, and you investigate the cause of the sudden toxicity.
Still under the umbrella of S-phase casualties, let's look at the gastrointestinal toxicity.
The GI toxicity is severe because, as we noted, the mucosal lining replaces itself constantly.
Clinically, early on, about 10 to 11% of patients will experience significant nausea and vomiting.
But if the toxicity progresses, it leads to severe diarrhea, stomatitis, GI perforation, and hemorrhagic enteritis.
Hemorrhagic enteritis. That means the digestive tract is literally ulcerating and bleeding from the mouth all the way to the colon.
It's brutal.
And what does stomatitis actually mean for a patient at the bedside? It's not just a minor inconvenience. It means they physically cannot swallow their pills. They are in agonizing pain.
They require magic mouthwash to numb the tissue just to drink water.
And those ulcers are open wounds, meaning the normal bacteria living in the mouth now have a direct pathway into the bloodstream of an immunosuppressed patient.
It is a massive infection risk. The nursing management here requires extreme vigilance regarding hydration.
You must interrupt therapy for severe vomiting or diarrhea. Why? Because vomiting and diarrhea lead to rapid dehydration.
And what happens when a patient is dehydrated on methotrexate?
The kidneys don't get enough blood flow, the urine output drops, the drug isn't cleared, it crystallizes, and the toxicity skyrockets. It's a terrifying self-feeding loop.
The drug causes vomiting. The vomiting causes dehydration. The dehydration causes the drug to build up in the blood, which causes more profound vomiting.
You have to break the cycle.
You do. You provide IV fluids, aggressive antiemetics, and you stop the methotrexate.
You also use extreme caution in patients with pre-existing GI diseases like peptic ulcer disease or ulcerative colitis, as their compromised tissue is at a vastly higher risk for catastrophic GI perforation.
Exactly.
Let's look at the dermatologic system, which is also an S-phase casualty. The box warnings go far beyond the expected hair loss.
Yes. Methotrexate can cause serious, sometimes fatal dermatologic reactions. We are talking about Stevens-Johnson syndrome, toxic epidermal necrolysis, and deep skin necrosis.
Wow.
And these can occur within days of administration, regardless of the route or the dose.
Let's explain the WHY behind Stevens-Johnson syndrome, or SJS. Why does an antimetabolite cause the skin to blister and peel off like a severe burn?
The epidermis, the outer layer of skin, relies on a basal layer of rapidly dividing cells to constantly replace the skin cells that flake off.
Right.
Methotrexate halts those basal cells in the S phase. When those foundational cells die, the structural integrity of the skin fails.
The epidermis essentially detaches from the dermis below it.
Yes. Fluid fills the space, creating massive blisters, and the top layer of skin slows off.
It is treated in intensive burn units because the patient loses their primary barrier against infection and fluid loss.
Exactly. Recovery requires immediate, permanent discontinuation of the drug and intensive supportive care. The drug also causes extreme photosensitivity, meaning patients are highly vulnerable to severe UV damage.
The manual mentions a phenomenon related to the skin called radiation recall reaction. What is that? It sounds like something out of science fiction.
It is a strange and deeply fascinating physiological response.
How does it work?
If a patient previously had radiation therapy for cancer or even just a very severe sunburn years ago, and that tissue fully healed,
Okay.
when they start methotrexate, that exact specific area of skin can spontaneously inflame, turn red, blister, and essentially recall the previous injury.
That is wild.
The tissue remembers the structural trauma, and the introduction of the drug reactivates the intense inflammatory response in that specific geographic area of the body.
Imagine being a patient. I had radiation 10 years ago on my shoulder, and now my skin is burning and blistering there again.
It's jarring. The nursing education here is paramount to prevent panic.
You monitor the skin closely, and you educate the patient forcefully that they must wear protective clothing and use high SPF sunscreen. They cannot go to the beach and sunbathe while on this medication.
Very true.
Okay, let's transition to the second group of box warnings, the filtration crisis, the liver, and the kidneys.
Hepatotoxicity is a major boxed warning. Methotrexate can cause severe, insidious, and potentially irreversible hepatotoxicity, including fibrosis, cirrhosis, and total liver failure.
And this usually occurs after prolonged use, right?
Typically 2 years or more of continuous therapy or after a cumulative lifetime dose of 1.5 grams.
The nursing management for this seems straightforward at first glance. We draw liver function tests, LFTs like AST and ALT, and check serum albumin every 1 to 2 months.
But there is a crucial, incredibly sneaky nuance in the text regarding psoriasis patients.
What's the nuance?
This is a vital point for clinical practice. In patients with rheumatoid arthritis, persistent LFT abnormalities or a drop in albumin usually provide an early warning system. They precede severe structural liver damage.
Okay.
But in patients with psoriasis, their LFTs and albumin are often completely deceptively normal despite the liver actively developing severe fibrosis or cirrhosis.
That is terrifying. The blood work lies to you.
It really does.
The liver is quietly scarring, turning hard and cirrhotic, and the standard metabolic panel shows everything is perfectly fine. How do you monitor that safely?
Because the standard inflammatory blood markers aren't reliable in psoriasis patients, the dermatological guidelines recommend periodic structural assessments based on the cumulative dose.
Meaning what exactly?
Historically, this meant forcing the patient to undergo an invasive liver biopsy after every 1 to 1.5 grams of total drug taken.
Ouch.
Yeah. However, modern guidelines now lean heavily toward non-invasive assessments of liver fibrosis at baseline and annually. This includes specialized serologic tests and something called transient elastography.
Let's ELI-5 transient elastography. That's essentially a highly specialized ultrasound machine that sends a vibration wave through the liver to measure the stiffness of the tissue, right?
Huh?
A normal liver is soft and bouncy, so the wave moves slowly. A fibrotic, scarred liver is stiff, so the wave travels much faster.
That is a brilliant summary. It measures the physical stiffness without needing a needle.
So the nursing implication here. If you have a psoriasis patient who has been on methotrexate for 5 years, do not just blindly rely on their normal LFTs and assume they are safe.
No, ensure they are getting their hepatology consults and their transient elastography to actually look at the structural health of the liver.
Excellent. Let's cover the renal system warning, which we touched on during the high-dose rescue discussion.
The boxed warning is irreversible acute renal failure, primarily caused by the physical precipitation of the drug and its metabolites, specifically 7-hydroxymethotrexate crystallizing in the renal tubules.
The nursing management is aggressive hydration, alkalinizing the urine to a pH of 7 or higher, and monitoring serum creatinine daily during high-dose therapy.
But there is an important note about dialysis in the manual.
Right. If the kidneys do fail and the patient goes into acute uremia, you can't just hook them up to a standard dialysis machine and clean the blood, right?
That's right, because methotrexate is highly bound to plasma proteins and distributes deeply into the body's tissues. Standard hemodialysis or peritoneal dialysis does not clear the drug effectively.
It just pulls it from the blood and then more leaches out from the tissues.
Exactly. If a patient is in acute renal failure from methotrexate toxicity, they require acute, intermittent hemodialysis using a highly specialized high-flux filter, or the administration of glucarpidase, as we discussed, to chop the drug up systemically.
Good to know. Finally, let's cover the outlier in the boxed warnings, the pulmonary system.
This one is entirely unpredictable.
Methotrexate can induce potentially fatal pulmonary toxicity, including acute or chronic interstitial pneumonitis. What does this look like clinically, and what is the mechanism?
This is one of the most feared toxicities because it is not strictly dose-dependent. It can occur acutely at any time during therapy, even after just a few doses, and at any dose level, low or high.
Wow.
It is an inflammatory hypersensitivity reaction in the lung tissue, and it is not always fully reversible. The red flag symptom, the primary clinical indicator you are listening for as a nurse, is a dry, non-productive cough.
Just a dry cough. That seems so innocuous. Patients in a hospital or a clinic cough all the time. It's allergy season or the air is dry.
It does seem innocuous, which is exactly why it is so dangerous. In the context of a patient taking methotrexate, a new, persistent, dry, non-productive cough must be treated as interstitial pneumonitis until definitively proven otherwise.
And if ignored?
If ignored, it can rapidly progress to high fever, severe dyspnea, sudden hypoxemia requiring intubation, and radiographic evidence of massive pulmonary infiltrates.
So what is the specific nursing management?
You must ensure the patient has a baseline chest x-ray before ever starting the drug.
Okay.
If an outpatient calls the clinic triage line or mentions casually at an appointment that they have developed a persistent dry cough, you instruct them to stop taking the medication immediately.
You interrupt the treatment and bring them in for an urgent, careful investigation.
Which usually involves a new high-resolution chest x-ray and full pulmonary function tests. You never simply tell them to take cough syrup and wait to see if it gets better.
Stop the drug for a dry cough. That is a very specific, actionable, life-saving nursing takeaway.
It absolutely is.
Okay, we've covered the box warnings. To finish the clinical profile, we need to address the reproductive system. We know it's contraindicated in pregnancy due to massive teratogenesis, but it also profoundly affects fertility in both sexes.
Yes. Clinically, methotrexate causes oligospermia in men, a severely low sperm count defective spermatogenesis resulting in damaged sperm, and severe menstrual dysfunction or amenorrhea in women.
It can cause outright infertility.
And the phrasing part is that it is currently unknown whether that infertility is fully reversible in all patients after stopping the drug.
That requires some very serious, compassionate, sit-down patient education before starting the therapy, especially for young patients with rheumatoid arthritis or psoriasis.
The contraception rules the manual lays out are incredibly strict.
Let's role-play that. If I'm a 25-year-old female starting this drug, what is the timeline?
Pregnancy testing must be performed and verified negative before the first dose is ever given. You must use highly effective contraception continuously during the entire course of therapy, and you must continue to use it for at least 6 full months after your final dose.
6 months after stopping. Because it takes that long for the body to completely clear the trapped polyglutamated drug from the tissues, and for the cellular division cycles to fully normalize.
Yes.
And what if I'm a male patient?
Males must use effective contraception during therapy and for at least 3 months after their final dose.
3 months. Why?
This is due to the severe risk of male-mediated teratogenicity. Methotrexate causes chromosomal damage directly to the sperm cells. If a damaged sperm fertilizes a healthy egg, it can lead to severe fetal anomalies and spontaneous abortion.
Okay, I have to step back and look at the big picture here.
It's a lot, I know.
This list of doxed warnings and side effects is genuinely terrifying. We've talked about Stevens-Johnson syndrome, peeling the skin off, hidden liver failure, sudden bone marrow collapse, fetal death, irreversible renal crystallization.
It sounds like a horror movie.
It does. How do nurses keep patients from having an absolute panic attack when educating them about this? If I'm a patient and you hand me this printout, I am throwing the pill bottle in the trash.
It's one of the greatest challenges in nursing communication. You have to balance strict informed consent with building a therapeutic alliance.
Right.
You cannot hide the risks, but you can frame them. The key is to heavily focus on the monitoring and the clinical safety nets.
You explained that these risks exist, which is exactly why this medication is prescribed by specialists and monitored by an experienced clinical team rather than just handed out over the counter.
Exactly. It's framing the constant monitoring not as a reaction to a crisis, but as the active prevention of one.
I like that.
You empower the patient by explaining why they are getting blood tests every month. You tell them, we check your blood so frequently to ensure the dose is absolutely perfect for your body, and so we can catch any microscopic changes long before you ever feel sick.
And you emphasize the control they have. If you get a dry cough, you have a direct line to call me immediately. If your knee hurts and you want to take an ibuprofen, call me first and we will find a safe alternative.
Exactly that. You make them an active partner in their own safety.
That's such a good approach.
You explain that with proper baselines, the CBC, the LFTs, the chest X-ray, and with strict adherence to the dosing schedule weekly, never daily, the toxicity is highly manageable, and the relief from their debilitating arthritis or psoriasis can be life-changing.
When patients know exactly what to look for and know they have a dedicated nurse watching their back, the fear is replaced by clinical vigilance.
That is phenomenal advice. Empowerment through education.
Okay, we have covered an immense amount of ground today. We've gone from the S phase of the cell cycle to a 2 a.m. rescue protocol.
Let's do a rapid-fire recap of the true 80-20 takeaways.
The absolute critical points that yield 80% of the clinical understanding for an exam or a shift.
First, dosing frequency. For non-malignant autoimmune diseases like RA and psoriasis, the dose is weekly, never daily. Daily dosing leads to catastrophic, fatal bone marrow suppression.
Second, the high-dose rescue. For massive IV cancer protocols, leucovorin rescue is the strictly timed mandatory parachute to save the healthy cells. It must be accompanied by aggressive IV hydration and urine alkalinization above a pH of 7 to prevent the kidneys from crystallizing.
Third, the deadly interaction. NSAIDs combined with methotrexate clamp down on renal blood flow, preventing clearance, which can cause fatal systemic toxicity.
Fourth, the absolute contraindication. Pregnancy is an absolute no in non-malignant use due to profound teratogenicity, and never use benzyl alcohol formulations in neonates or intrathecally to prevent gasping syndrome.
And fifth, the pulmonary red flag. A persistent, dry, non-productive cough is not an allergy. It requires immediate cessation of the drug and investigation for potentially fatal interstitial pneumonitis.
Fantastic. As we wrap up this deep dive, I want to leave you with a final thought to mull over. We spent the last hour talking about mechanics, the dangers, and the strict rules of administration. But when you step back, there is a profound, almost poetic elegance to how this drug functions at the microscopic level.
There really is. If we connect this all the way back to the very beginning of our conversation, consider the deep irony of methotrexate's cellular mechanism.
Right, the polyglutamation.
Yeah, how the cell actively attaches an anchor to the drug, trapping it inside. The very process a cancer cell uses to survive, pulling in nutrients, hoarding them, and trapping them to fuel its own chaotic, rapid division.
Is the exact mechanism that traps methotrexate inside the cell.
The drug turns the cancer cell's own greedy biology into the instrument of its destruction.
It forces the cell to build its own prison.
It does. As a nurse, you aren't just hanging a bag of fluids or handing over a pill. You are managing a chemical tool that uses the body's own metabolic hunger against itself to save the patient's life.
It's an incredibly powerful tool, and respecting that power, understanding the why behind it, is what separates a task doer from an excellent clinician.
A perfect, sobering thought to end on.
Thank you to everyone out there listening. We know you are drinking from a fire hose in nursing school, and the clinical floors can feel overwhelming, but you've got this. Review your notes, trust your assessments, remember to look for the why behind the whats, and go ace those exams. We will catch you on the next deep dive.